My name is Doreen Sherman. I'm with the National Action Alliance for Suicide Prevention, and I'm very happy to be here. We're going to hopefully get to see and thank Representative Napolitano and Representative Katko for hosting this important briefing today. But I spoke too soon.
Hello.
Hello, come in. I just started.
How are you?
Good, Doreen Sherman.
Hi, Doreen. How are you? Nice to see you.
Nice to see you.
Where's the Congresswoman? Is she here yet, or?
Not yet.
Okay, John Katko. How are you? Nice to see you. Hi, Jane. How are you? So how do you want to proceed here?
We thought we would get started because of the
Absolutely,
time.
sure.
So maybe, would you like to say hello to the group?
I would love to, if I may, just talk a couple things, and then I'd love, really looking forward to hearing from all of you, so thank you for being here. Like many American families, my family's been touched by suicide, and it's probably one of the most devastating things that ever happened to our family. And it's hard to describe the finality of the suicide, or as opposed to other illnesses. It's until you've gone through it, it's very, very hard to describe the impact it has on the family as well. So I'm really proud to be here. This is something I feel very passionate about, and I'm looking forward to hearing from all of you because of what the issues are with respect to research that we need to do better at. And I just want to talk about a couple of things. Suicide is the 10th leading cause of death nationwide, affecting individuals across all ages. And here's something that kind of really got me, having 3 teenage boys, is it's the second leading cause of death among youth. Am I correct? Yes. That is an unbelievable statistic. More than 30,000 people in the United States die every year by suicide. 30,000. Hello, Congresswoman. It's also widely underreported as well. But here's another fact for you that really jumps out at me. 22 veterans a day. 22 veterans a day commit suicide. That's 1 every 65 minutes. By the time this hearing is over, another veteran will probably commit suicide. What are we doing? This is an epidemic in this country, and I really, really strongly believe that. So I'm looking forward to hearing from the Congresswoman. I'm so glad that we're reaching across the aisle in a bipartisan manner. We're working on an issue that's of great importance in this country. This is one of the issues you put politics aside and you work together, hand in hand, across the aisle. And so anything I can do to help, I will. And I look forward to you, to the next hour for you to educate me. And so without further ado, I want to let the first speaker come up here, and let's get going. So, thank you.
Thank you, Mr. Katko. It's a pleasure working with you and your staff. We want to thank the Action Alliance, of course, NAMI, and the American Foundation for Suicide Prevention for working with us. But it is an issue that transcends parties. I think all of us are affected one way or another, our families, our co-workers, our friends, our businesses. But we're pleased to continue working with our advocates on mental health. It's an issue that is not going to go away. In my 17 years in Congress, when I first came here, nobody wanted to talk about it. It was, what would I say, a no-no. You didn't talk about it, you didn't discuss it. You certainly didn't want to admit that there was such an issue prevailing in our society. But with the help of others, we continue to push the envelope. We continue to reach out to members on both sides of the aisle, because it's something that some of the members, my colleagues, are saying it affected their lives. And so all of us need to be able to be above board, transparent, and saying we need to work together. But you need to be part of what drives us to be able to get those changes effective. Not just me, not just Mr. Katko, not just all of us need to be able to work with our allies and be able to bring that issue up. Whether it's a gun violence issue, again, everybody blames the mentally ill, the crazies, if you will, and that's not true. So how do we bring that awareness and joining the media, making them aware, making the entertainment industry issue, the solution, so that they understand that when they reach out to the broader crowd, the viewing public, that they understand that this is an issue that we all are affected by, and the solutions may not always be evident, but somehow we need to be able to understand there are solutions, and we working together, at least we can address them. It is what we call the invisible illness. But again, we've formulated a task force in my area, mental health providers, schools, law enforcement, everybody. We're working to advise me, especially my area, on what do we need to do in Congress, and we give them all kinds of information, the bill numbers, the contact numbers, so that they too can begin to look at what's being offered, where it's being offered. I must say that it's been an eye-opener for me. I have a mental health hospital in my backyard that I've been there 54 years, so I understand some of those issues. And I dealt with them when I was in the state assembly, because it was part of the budget that the federal government was cutting down, closing mental health hospitals with no safety net. So you understand these goes back for me for a long time. The education issue, educating colleagues, congressional colleagues, their staff, the parents, school officials, everybody, because it's becoming more of awareness that universities have one of the highest suicide attempts. And we're not dealing with that. What about the foster children who also are having a high suicide rate? Latin adolescents who have the highest percentage of suicide attempts in the United States. And we don't bring those facts out, and so it's kind of like, yeah, it's there, but we don't worry about it because nobody talks about it. It's not just the social and cost to the family, it's economics. Businesses with billions of dollars. It's the 10th rate cost of Americans, and as my colleague was saying, we're losing 22 veterans a day to this day. This has been a figure that's been around now for at least 3 years. 22 a day, and it's not slowing down. They try to assess what's causing it, how can they address it, and somehow they really haven't been able to narrow it down, pinpoint it, and be able to address it. Whether there's some that serve abroad, some that are not going abroad, they're homeless and commit suicide. 44 billion annually cost to business. Billion annually cost to business. These families suffer in silence because of the stigma. So how do we tell those families there's maybe organizations that may be able to help you, and they're nonprofits, they're funded by the federal, state, or county governments, that you need to understand are there. How do we get those websites, that information across? And then change some of the policy that some of those areas may have. How do we get the American Civil Liberties Union to understand that an over 21-year-old still needs help from the parents and should be able to get a commitment to be able to have them get service, even though that child may say, no, I don't need them, and be a danger to themselves and to society. Then, of course, there's the other area of the attempted suicide. That for every, for every suicide, approximately 12 attempt suicide. 12, not completed. The federal investment is critical, but we also must make sure that, like in California, they passed a bond many years, well, about 5 years ago, taxing the super wealthy to be able to put more funding into mental health. With that kind of funding, we were able to expand our program from 3 schools now to 26 schools. It is successful. There's schools waiting to get online for on-site school services, and that's how my bill at 291 is predicated on. The suicide rates, they haven't gone down in 50 years. Not gone down. And all the effort, all the emphasis, everything we're trying to do, and it's still not there. So please, learn the warning signs. You have a lot of information and see. Use them, ask questions, finish talking to the websites, find the verbal cues, talk to families, do whatever you can, because this is a crisis. And you have handouts that you can learn from. You have a confidential 24-hour hotline. And with that, I'll turn it over to our distinguished panel, and I thank you very much for being here. It is really a pleasure to see the interest from some. Even though I don't have a lot of members, but at least please take it to your home office. Thank you.
National Action Alliance for Suicide Prevention, and I'm delighted to be here. And I want to thank Representative Katko so much, Representative Napolitano, for both your commitments to mental health and suicide prevention, and we're hoping to be able to spend an important hour together. Today is World Suicide Prevention Day. In our world, every day is Suicide Prevention Day, and we look forward to bringing some important information to you that might turn the tide. As we heard, we lose over 40,000 people every day, but that's just the tip of the iceberg. Of course, under that are all the people that attempt, all the people that are in such distress that they think about ending their lives. But like Mr. Katko said, the ripple effects on families and friends and employers is tremendous in this country. But we are poised, in large part because of the research agenda that we have to talk about today, we're poised to make some changes that are going to turn that tide around. Today is 5 years since the National Action Alliance for Suicide Prevention. I'm never good at keeping up here. Well, maybe it's because this isn't working. There you go. That's me. Am I going the wrong way? Yeah, that's it. Okay. Today is 5 years since the National Action Alliance for Suicide Prevention has been launched. It is the public-private partnership for suicide prevention in this country. And we are tasked with implementing the National Strategy for Suicide Prevention, which is the roadmap that all organizations use to say, if we're going to adopt priorities, what are those priorities? If we're going to leverage change, what are the changes that we're going to leverage? The national strategy was developed in conjunction with Surgeon General Regina Benjamin. But let me just say that the National Action Alliance for Suicide Prevention has 200 organizations, all devoted to working with to prevent suicide. And those organizations are people that come together, very high-level people that come together, all as volunteers, because they care about, in their sector and in their communities and in their spheres of influence, to change the trajectory of suicide in this country. And so we are so grateful to those organizations. And I'd like to just give you a hint of the types of organizations that come together under the Action Alliance. We have Facebook, we have the Entertainment Industries Council, we have Union Pacific Railroad, we have the Kennedy Forum, the National Council for Behavioral Health. You have this on the slide, you'll be able to see it, but we also have the National Football League, and we have Kaiser Permanente, Universal Health Services, and so there's such a groundswell of interest and commitment to the issue of suicide prevention. And we are very fortunate that Representative Napolitano is on our executive committee, and she has been a long-standing champion of mental health and suicide prevention as a national priority. But also on the public sector side, we have so many public servants and our government agencies that are working hand in glove with the private sector to advance the issue of suicide prevention. And that includes HHS, the Department of Defense, Veterans Affairs, Department of Interior, Department of Education. So this public-private partnership has been advancing really important suicide activities. But it's poising us to, we are now poised to take the national strategy, move it forward, but to move forward, I just want to illustrate a couple of initiatives that are ripe for making major change in this country. One is the Zero Suicide Initiative. Zero suicide. What is zero suicide? We are looking in our nation's healthcare and behavioral health care to bring the issue of suicide of people in healthcare systems and behavioral health care, not to 10 or 20, but to zero, because that's the only thing that we can expect and expect. It's an aspirational goal, but it's a goal we're working with. Right now, we have 150 organizations that we're working with to implement the zero suicide model, which is an evidence-based model. It's the whole notion of transforming a health system to drive to suicide to zero. And we're very happy to discuss that with you if you're interested in more. I want to also just highlight a couple of other issues. One is, under the leadership of Dr. Tom Insel at the National Institutes of Mental Health and Mr. Philip Satow at the Jen Foundation, we were able to develop another roadmap, which was a research roadmap. A research roadmap which tells us if we implement the research we need with the fidelity that we need, meaning that we do the research the way it needs to be done, we can save 20,000 lives in 5 years. And Dr. Pearson's going to be telling us about that. She was instrumental in this very important research prioritization. You have it on your chairs here, and we can certainly give you more information. But also was instrumental in doing a portfolio analysis across the federal government to see where investments in suicide prevention are happening. And you'll be maybe not surprised to know that the 10th leading cause of death certainly does not have the kinds of investment that we need to turn the trajectory the way it needs to go. And so I would like to just close by saying that we just did a poll a few weeks ago of 2,000 Americans to find out about their attitudes about suicide and mental health, to find out about what they know and their own experience with suicide. This was done with the American Foundation for Suicide Prevention. John is the vice president there, and with the Anxiety and Depression Association of America. And there are many findings, but the one I want to point out is that 3 in 5 Americans believe we need more research in suicide prevention. So it's not just those of us in the field that think that there needs to be more that we need to know, but a majority of American adults say that we need to know more about why people die by suicide and how to reduce the numbers. And so we look forward to sharing that information with you. We look forward to working with you. And it is my great pleasure to introduce Dr. Jane Pearson of the National Institute of Mental Health.
Good afternoon, everybody, and thank you so much for coming. My name is got lots of other hands. So this is what I started working on in 2010 in terms of how we're looking at our research. And part of that was driven by our national strategy that says we should have a prioritized way of looking at research. We really don't have a lot of time to just kind of hang out and see what results bubble to the top that we could use. We really have to get moving on this. The other document, as Doreen mentioned, is portfolio analysis. My job at NIH is to oversee suicide research, and NIH is one of the major funders of suicide within HHS. But there's a lot of others, and we're going to talk a little bit about those, and some were actually even surprising to me. So one of the things we had to do in this task force was figure out how we're going to prioritize. And Doreen mentioned reducing suicides at 20% in 5 years. Now, if you know anything about research, you know we could not spin out as fast as we could any study that would actually, do that. So we had to think about how could that be projected. And we took a lesson from Mother's Day from driving. In that effort, people were looking at blood alcohol levels, and at the time it was 0.1. And what happened is the National Alcohol Institute looked at what would happen if you reduce that so it's a much more conservative level, less alcohol in blood. How many lives would you save? They came up with a figure of 500. So you get a bunch of angry moms coming to the Hill saying, you know what, if you lower this, we're going to save lives. How could you argue with that? So we kind of took that lesson and said, okay, let's think about what things we might have right now, if we implemented them, that could actually make a difference. So we've looked at, patterns. Why has homicide gone down over the years and suicide hasn't? What's happening? So we established the school within that research task force, and actually the co-chairs that Doreen mentioned Dr. Inslow and Mr. Satow were like, we've got to really make this count. We can't just, hope that the research makes a difference. This slide's very busy, and I just want to have it in here to let you know we really try to do our homework to figure out how to prioritize research. And there's always a science to everything. There's a science to prioritizing research. We actually talked to our colleagues in Australia and Canada and said, we know you guys have been thinking about how to fund research. What did you do? What did you learn? And we had some really good advice. One of them was go to a very broad group of stakeholders. Go to family members who've lost somebody by suicide, people who've attempted, clinicians, public health people, law enforcement. What do they see that they need? And this actually comes from good science showing you can actually do better science if you actually talk to the stakeholders who are going to use the science. Surprise! So we did that, and so we did start with the researchers first. We started out with all these broad stakeholders, asked them for all of their ideas. We also tried to think about where people had been right before they died by suicide, because we knew we had to try to make different organizations accountable. Who could have helped that person? Who could have helped that person through the school, a healthcare setting, jails, prisons, so on. So we started working on, it's hard to see what these are from where you're sitting. You've got the handouts, which is probably also pretty small too, but if you go to the right circles, we tried to think about all the people who died by suicide, and you heard about the number of veterans dying every day. We said, of all of those people, this was back in 2010, there were 38,000 deaths at the time. How many of them were veterans? How many of them were veterans engaged in VHA care or outside that care? How many people were in the military? At that point, we were just starting this Army STARS project. Got a lot of press. The military would reveal its, or the Army would reveal its numbers every month, and everybody thought, wow, these must be huge numbers. That's 300 people. So when you start putting all these numbers together and thinking, where are all these deaths happening, you start getting a sense of where we might need to target our efforts. Over half of the individuals in this country who die by suicide use a firearm. And we figured out if we actually reduced that a little bit, it would have such an impact, because that's the common method used. And most countries have figured out how to reduce their suicide rates by focusing on methods. We, of course, have a big challenge in front of us trying to think that through, but we're working on it. The triangle on the left there is more about attempts. And you heard that there's many more attempts than deaths. And we're glad that happens in this country, that people can get rescued, that they don't die from attempts. But it also segments, we try to think about where we can find people who had recently attempted. So we know people come to emergency room with attempts, and we were looking at those numbers. We know that in outpatient care, in mental health outpatient care, we know people have histories of attempts, sometimes become distressed, make attempts, substance abuse. We've got parole. The high school youth risk behavior survey is another way of looking at adolescents in high school, how many of them have attempted suicide. And even in college, we're getting more consistent measures of how many kids in college report having attempts. So this starts mapping out where do we need to focus if we really want to change numbers. So we thought, let's see if we can actually get to 20% if we modeled out some of these interventions. And just using 3 approaches. The blue side there is the firearm piece, because as I mentioned, if we could reduce that a little bit, that's just reducing it by 25%. We're already halfway to our 20% reduction. And we were actually looking at the trends over time. There are fewer households with firearms, but it's probably that those households have more firearms. But we thought if that trend continues, that's fewer people exposed to a firearm on an ongoing basis. What we're trying to discuss now and trying to work on is at least discussing people who are in distress shouldn't have access to a firearm. And there's lots of ways we can think about that, through clinical care, through family members, and so on. So I think there's some ways forward there, but we really need to work on that. The green box there, or the section of the pie, is psychotherapy that's offered to people who have attempted suicide and have been seen in the emergency room. And we know from our research that we can reduce their re-attempt rate, like we can not let them relapse, we can prevent them from reattempting 30 to 50%, in some cases 60%. And this has been shown with men in the military, many studies, people with borderline personality disorder, homeless people, it's kind of across the board. And part of that treatment that's most effective is really talking to somebody directly about their suicide. Not just hoping, treating their depression, treating their anxiety will make the suicide go away. We want to do that too, but we really have to save somebody by focusing on the suicide. This doesn't even get to thinking about people who are thinking about suicide and then helping them. That would be a little bit easier than waiting until somebody attempts. So we're actually starting to work on research there. Just to tell you what's in the research agenda, and I'm not going to read through all these things, but that survey that I mentioned, or I should say all the stakeholders I mentioned that we want to get input, we did an online survey to get their input. And we said to them, if you could come up with 2 research ideas that you think would really make a difference, what would those research areas be, or how would you think about it? Over 700 people all had at least 2 ideas, most had 3. So we had thousands of ideas, and many of them were complex and appropriately complex, because if you had an idea about screening, you have to have somebody follow up somebody who's screening. And if they're in the care system, you want to follow them. Or if somebody had an idea about, let's get kids more resilient in the first place, and we want to go down that route, what does that take? So we started organizing what we call aspirational goals under kind of general areas of suicide research, and it's kind of general areas of science. So the first question is why? Sort of the etiology. Why do people become suicidal? So this is where maybe our biomarkers could come in. It could be under social trends. It could be, what's the contagion phenomena among young people? So those are questions referring to why. Question 2 was, how can we detect risk? How would we know somebody's at risk, right at, before they behave? But we'd like to go up a little bit, further to help them sooner than right before they're in distress. And that's been a challenge in the field. What interventions? I've mentioned psychotherapy being quite effective. There's all kinds of different ways of thinking about when medications could be used. Very few tests on medications in this field. Mostly because pharmaceuticals don't want to have deaths in their trials. People are actually excluded from a lot of mental health problems in pharmaceutical trials because pharmaceuticals don't want to show that this medication was associated with a death. So here's the most vulnerable group of people not even getting into trials in the pharmaceutical industry. There's one indicated olanzapine for schizophrenia that has showed a reduction in suicide. If we think about the service system, and we're at a point now where lots of things are happening in healthcare, and at least 50 experiments across all the states. Everybody's doing something a little bit differently. We've got a lot of opportunities to think about, especially through the zero suicide effort, how could we move forward to make our healthcare systems safer for suicide? If you think about this, if you knew somebody who was distressed and you wanted to take them someplace that you thought would help them, I think you'd assume behavioral health, emergency room, someplace like that would be the place to go, right? Well, unfortunately, a lot of providers are not trained in what to do. And you personally, or might have friends who've had experiences in these healthcare systems that are not so optimal. So we want to make sure that starts changing. That's got to be a place that's safe. Because if we're going to encourage people to get help, we want to make sure they get help. And we need those kinds of stories to make sure that helps. Yes.
I want to interject here, because this is a huge problem in Central New York. For pediatric, for kids under the age of 18 especially, Syracuse is a metropolitan area, 500,000 people, maybe more in the 4-county area. And within an hour's drive, you probably got 1 million people, probably close. There's no inpatient pediatric facility for mental health. None. Now, we have the University Hospital there, which is a teaching hospital. We have 3 or 4 major hospitals in Syracuse alone. And people have to drive sometimes hours to get inpatient mental health for the kids. So what happens? 2 things. Number 1, they don't send the kids because they can't afford to take off time from work. And the follow-up care that's necessary after a crisis has passed is not getting done.
Right.
And even if they do go to these facilities, the stress on the family, having to go to these facilities so far away, and they have to take time off from their jobs, I mean, it's a nightmare. So I formed a mental health task force in Syracuse, and one of our primary goals is to get inpatient pediatric mental health treatment. And don't know if we're going to get it, but we're working on it.
It's very difficult.
That is one of those quiet problems with mental health. And that's one of the reasons why I think you'll see the second leading cause of death for kids is suicide, because there's not the treatment for them.
Yeah.
Which is the reason why I introduced my bill for mental health in schools, is because if you have it on-site clinician care, not only dealing with the student, teaching the administrators, the teachers, but also working with the parents to help them identify what is wrong with the child and help the child get better.
And do it earlier, before you're at that crisis
Kindergarten,
point.
high school.
So that's what, question 5 is about. How can we think about some of these earlier interventions that we have in the communities working? And also thinking about means restriction. So, does the pharmaceutical drop off, get rid of your extra meds, stuff actually help reduce overdoses that are related to suicide? We'd like to see that. We'd like to know if some of the bridge barriers work that we often hear about in the press. So there's a lot of research that we'd like to do, and I've already mentioned the firearm piece. Question 6, we borrowed from the autism strategic plan. And that was to think about how are we doing the research so we can make it count more, because we know we have very limited dollars. We'd love to have more, but we don't really see a big opportunity yet for a huge increase. So we really have to do the best we can with what we've got. So we're trying to think of how to use common measures across studies, how to get people to share their data, so we could reanalyze things and start putting a lot of pieces together. So there could be some opportunities, for example, with understanding resilience. What makes kids resilient against thinking about suicide ideation? And could we promote that some more in our schools? So we're actually having a meeting at NIH to address that next March, and we're really looking forward to seeing what kind of data we can have access to.
Is there a possibility that you can start looking at impressing upon the medical schools to teach nurses, dentists, doctors, everybody, the beginning of understanding when a patient comes in and being able to understand this may be a tendency to?
Right. So there's been an effort at IOM trying to look at good measures of kids early on to start detecting and building in prevention that way, because it's a challenge to figure out where does prevention sit, because there's some early detection pieces, but you almost need that longitudinal data to know you're capturing the right information. So I think as we get more access to more data through the medical record and can look at this, we have a study that I'll mention in a moment.
I'm talking about actually teaching the
Oh,
medical school, and dental school, and nursing school,
right.
be able to teach them the basics.
We have clinical workforce guidelines that we've developed for clinicians, for all kinds of clinicians. And the issue is really getting the different, the nursing association, the medical association, the getting them all to adopt them. So
Would you get that info to us? I think
I will get you that
spread it out to
information.
everybody.
And the other thing, Grace, we're working at the state level, we're working on legislation to require all medical professionals to be trained on suicide prevention,
Excellent.
especially the primary care physicians and the nurses, because again, to the Congressman's point, with the dearth of mental health providers, the primary care setting is the primary place where most folks get help. They need to be trained about the warning signs and what's going on, so we can share information.
Including promotoras from visit home to home.
Exactly.
Right, there's great prevention models, home visitation, where you can get people trained as lay people, and there's a lot of interest in peer supports with veterans. There's just so many opportunities where I think we could spread some knowledge. The report that Doreen's describing is like basic principles that every care provider should have, and you can think about specialization for that.
We can get the word out to all the folks and the media.
Yeah. And then there's that demand side. If you're a family member, you should be asking these questions in your healthcare system. You got to get the demand side up. So yes, get the word out. There's effective treatments. There's things we can do, and then people have to demand it and get it going. And the portfolio analysis. Let's see. Yeah, you got that in the agenda on your chairs. Lucky you. What we did was, as part of that big, how to prioritize research, we had to figure out what are we already funding, and is it covering those key questions and even some of those aspirational goals. So what we found was putting together all these years, 2008 to 2013, 383 studies, and this went across 9 different federal agencies. The railroad agency that was mentioned, Federal Administration of Railroads, Justice Department has actually been looking at our radar detection for people who would be trying to heal themselves if you don't detect breathing. And there's technologies out there we could actually move out and save lives. So we have this all on a website. If you actually want to look through all the studies, the abstracts are on there. You can kind of search and see what's in there. One of the major findings, and John will be talking about this shortly, is that despite all of this effort, it is really meager funding if you think about the 10th leading cause of death. That's probably all I should say as government official. In terms of.
Please be open, transparent, honest.
Well, I'll get to some transparent findings in a moment. So this is the conclusion from the portfolio analysis. It's pretty lean. But I would say we were able to find some gaps. So there's a lot of effort trying to educate teachers, parents, people in the communities. You know, if you hear somebody talking about suicide, get them to help. We need to evaluate those. So we've got a lot of goodwill and a lot of good passion about trying to help people, but we have to make sure they work. So if people are putting, you know, all of this effort into, we want to make sure it's good. Public health messaging, those are all important things. I mentioned the access to legal means as being a big area we need to do. I would say that funders have worked together quite well. We've worked with AFSP at NIH quite a bit around suicide prevention, and we actually did that even before the action line started. And AFSP does this critical role of getting new investigators started with pilot money. And they can, you know, sort out the kinks in the protocols, they can get some pilot findings, and then they come to NIH for even bigger funds. And not even just NIH, we're happy to see this go to the Alcohol Institute, Drug Institute, so we can get a broader swath of suicide research going. So we know what these gaps are, we're working together, we've already had 2 meetings of all these funders, and we're trying to figure out ways to leverage each other's investments. So I have some examples of what we know and how we're moving ahead, but I want to make sure we've got time for John and some questions. So let me just say quickly, we funded a study, we figured out how to do the screening and emergency room better. We can double the detection of people at risk. And there's findings that will be coming out shortly showing we can actually help prevent reattempts too. Most of that work had been done in UK, but we're actually trying it here at 8 different sites. In terms of youth, this is a real challenge because everybody, any parent is so nervous about their kid if they've attempted suicide or have thoughts of it. If you have an inpatient setting, is it getting overused? Is it not appropriate to put, you know, your child in there? It's very difficult to figure out among kids who's at risk, who's not. They don't have a good understanding of the lethality. You know, does 2 Tylenol just, you know, put you over, or does it make you sleep? Or do 20 Tylenol taken by a kid thinking, I'm just going to sleep really good? You know, they just don't have that understanding. So we really have to think about what their intent is, you know, some of those actions, and really help some decision-making trees for people trying to help kids. So there's that example. I just want to mention a study from the Danes. They have, you know, healthcare systems that have lots of medical records. There's registries of people who've been through care systems. They can link it to vital statistics. And this, I call this my psychotherapy in the wild study. Because since 1992, in Denmark, if you had attempted suicide, you were asked to go to a clinic that actually specialized in this and really helped you. And what they did was a look back of everybody who had access to that type of treatment in their healthcare system, had reduced their risk for another attempt by 16%, reduced their risk for death by 25%, and reduced their risk for death at any cost by 31%, because we know people who attempt suicide don't take care of themselves, they have GI problems, cardiovascular problems, they die from accidents. So it's like, no, what works? There's, you know, it's going on in other countries. We need to do it here. Okay, so we've got one more study I just want to mention. So instead of waiting until somebody's attempted, you know, to help them, that's kind of like dealing with cardiovascular disease by waiting for a heart attack. It's not really optimal. We want to move up, you know, in terms of helping people not get to that point in their health. If we could detect people who have suicide ideation and help them at that point, we'd like to do this. So this is a study run through the Mental Health Research Network with 20,000 patients who automatically get detected because they filled out this PHQ, Patient Health Questionnaire. If they responded yes to, I've thought about suicide quite a bit, they can get randomized to 1 of 3 conditions. So this is just starting. It's going to be across 3 large healthcare networks, and we're really excited about this. This is like the biggest study we've had. There's a lot of things to work out, but we're really excited about it. Here's the transparency piece. Dr. Ensel at NIH has been really clear about figuring out where we're investing at NIH. He had one piece looking at suicide research total across all of NIH, where it was pretty close to the bottom. Here, even within NIH, where we do feel like we're getting good applications, which is we're not getting enough applications, suicide is this pink line on the bottom, it kind of shows a little bump in 2012 and slowing down in 2013 compared to all of our other disorders. So what do we need? We need more trials. And I have, if this was tomorrow, I'd be able to tell you about something we're funding in with the justice system. Really happy to be cooperating with them. Hopefully we'll have a press announcement about that soon. And then we also have an initiative around zero suicide that we hope to get off the ground. So thank you.
Jane, thank you. I'm John Madigan. I'm the Vice President for Public Policy for the American Foundation for Suicide Prevention. Congressman, I lost my sister in 1997 to suicide, so I know the pain that your family has gone through and will go through. I'm going to be real brief because I'm batting cleanup. This is almost, we're getting to World Series times, and the Miracle Mets, 1969. That was the year that I started watching baseball. My mom would be sitting with a TV tray in the living room and watch the Miracle Mets win their first World Series back in 1969. So bottom line, why are we here? Why is the report that Jane worked on, why is the report that the Action Alliance worked on? Find this sheet in your handouts, okay? I started my career here in Washington back in 1977. I was an intern on the Senate side. I then became the lead lobbyist for the American Cancer Society. Back in the 80s, federal money was readily available, and all of you that work in congressional offices, how many of you have your constituents come in and say they want 10 million more for this or 500 million more for that? Back in the 80s, I could walk into a congressional office and I could say, give us a 10% increase for the National Cancer Institute. No questions asked, they did it. Now, we know money's very tight. So the report that the Action Alliance has worked on is a virtual roadmap. If the Congress will invest in suicide prevention research, we can show all members of Congress precisely where they ought to spend that money. It's almost like investing in a new business, okay? And then to the Congressman's point, and to the leadership that Grace has provided all these years, this is the 10th leading cause of death. People are stunned when they realize that 10 to 24-year-olds in this country is the second leading cause of death, and we're not investing the kind of money. So again, take a look at the chart. Look at the investment that's been done for 5 or 6 disease areas, okay? So we can show clearly, as you invest in these areas, the downturn in mortality. So our request is very simple. We're looking for any one of you or several of you to get your bosses to agree to offer an amendment to Tim Murphy's bill to increase funding for the National Institutes of Mental Health to at least $125 million, okay? Trevor Summerfield is right back here. Give him your business card if you want us to come talk. Also, here's the national fact sheet. We also have state fact sheets, so if you haven't gotten your state fact sheet, we can get that to you too. Also, to Jane's point in the back, there's a small booklet. This gives you, in layman terms, exactly the kind of research grants that we fund. And then to her point, we do funding somewhere around $50, $100, $200,000 seed funding. Then they go to NIH to do the larger research funding program. So clearly, we need $500 million. We need $1 billion, quite frankly, but we have to be practical. So again, we're making a big plea. $125 million down payment on the 10th leading cause of death. Help us do that, and we will see if we can help families like Congressman Katko and my family not go through what we've done. Grace?
What's the section of that bill?
What's the bill number, Trevor?
2646, but I can send it, Joe, to the section.
There hasn't been an amendment submitted yet, right?
What's that, sir?
There hasn't been an amendment submitted yet?
No, they actually have a provision in there for $40 million, and Dr. Murphy is aware of what we're doing. We're talking to Senator Cassidy and Senator Murphy on the Senate side about doing a similar bill. We had a bill in the last Congress that was called the Sprint Act that would have doubled the funding to $80 million. So we think it's doable. We're willing to sit down. I mean, we came up with one crazy idea with the pay for. We said, and Jamie, put your hands over your ears, we said that each institute within the National Institutes of Mental Health gave 1/10 or 1/16 of their total budgets. And that's money lying around in the closet somewhere. and decided to give it to Dr. Insel and to Jane, that again would be a serious way for us to make a big dent. And if we can reduce suicide, there are some things that we can do, like on the gun safety issue. There are no laws that have to be passed. All we have to do is get gun-owning families. We don't need to take away guns. We need to educate people who own guns about safety. It's very simple. Government doesn't have to get involved. There are lots of research that has to be done on pediatric issues or whatever that requires basic bench science that we have to fund.
John, will you draft something and then give it to my colleague, and then
Yes,
we'll
ma'am.
just try to get the members of the caucus to endorse?
Yeah,
Absolutely.
What I'd like to have you do is come meet my office with Aaron over there.
I talked to Aaron earlier.
Yeah,
Sir.
okay, and just come over and kind of lay out, I mean, obviously the pay fors are what we're gonna wanna know about, but, you know, so definitely, I'm very interested in this, okay?
And I think
So,
Dr. Murphy is too.
and I think working together,
To carry the weight.
I'm interested in doing this, and, because what people don't understand is they look at the dollars and cents of the budget, but the long-term economic impact of suicide is much worse, right? So, one quick question I have though, it's aside from this, but Aaron, I wanna make sure we follow up in soon on this. The other, is the awareness issue. How do we get out there the message that suicide, I'm overwhelmed by that. That suicide is the second leading cause of death for children in this country. How do we publicize it? How do we get that out there?
You know, I think you're just hitting on a very important issue, which is that people don't know. There's a tremendous amount of stigma. What I'd like to do is I'm going to share with Aaron some of the new poll results that we just did about what Americans do know and what they don't know. And so the question is, then we can maybe look at ways to communicate and to communicate more effectively about it. Because, you know, I think what's surprising about these poll results is that people have 55% of Americans in this poll have had somebody in their lives that either taken their lives or attempted or thought about it. 55% of Americans.
Rather than talking about it, why don't you start a series of op-ed pieces that he and I can co-sponsor?
Yeah,
And get that, you wanna get the media alert. But you're not gonna get it by talking about it here, you're gonna get it by getting to the media, being aware from members of Congress and saying, do you know that?
Find people
There you
big
go.
mouths like us.
But do a series of it, not just one and then forget about it.
Yep.
The other thing that we're doing at the state and local level, and I told Aaron that we would let you, sir, know about it, and Grace will let you know, we have 350 community walks across the country this fall, so if any of your bosses want to come and speak, at those walks, we have nearly 500,000
Send a
people
list of them and
attending.
we'll pass it around to our members.
And we're passing out information on the warning signs and getting people educated about what to do and where to
Yeah, I've
go.
done those walks in the Syracuse area, and I try to highlight it, and that's part of what this mental health task force is about, and it's getting covered, but it's every parent should know that it's the second highest cause of death.
Every pediatrician, when the child goes for their kindergarten inoculations, the parents should be asked, how are your kids doing from the neck up?
Yeah.
At the very early age.
And both pediatricians and adolescent medicine doctors should ask kids about their mental, you know, how they're doing, what they're
With a
thinking
few
about.
questions, if you develop a questionnaire,
Takes-
be able to have them in their hands when they talk to the
Absolutely.
children or the parent.
And it takes, and one thing is that some people think that if you talk about suicide, it's gonna put the concept into somebody's head. Not at all. It's talking about suicide that helps people get the help they need. And a lot of times, if you can get somebody to postpone an attempt, just postpone for 10, 20 minutes, it can change that impulse. But there's a lot that we'd love to work with you on. We have cards here. We'd be very happy to help in any way, and we stand behind what you're doing and appreciate what you all
And
are
the
doing.
staff input would be valuable because you guys are at the front of some of these things.
Yeah.
We gotta go vote, I think.
Yes, okay.
Well, thank you guys very much. I'm sorry. I gotta go vote. Thank you. Please
I was
come
just
to-
wondering, so you're talking about awareness, but are you also looking about systemic issues, like pediatricians? There's a deficit of pediatric psychiatrists. To see a psychiatrist is gonna be, as an inpatient, 7, 8 months. Psychiatrists won't see a child under 5, so you need like developmental psychologists. So, you know, that's also talking about pediatrics a huge.
That's, if I may interject, that's part of what our task force is trying to reveal, is the lack of that, like in medical schools. I'm sure this is buried out, but upstate medical schools in Syracuse, it's a big school. It's virtually none of them are coming out specialized in pediatric mental health, zero. So we figured out ways of maybe incentivizing to do that, student loan forgiveness, stuff like that, look at that.
That'd be
maybe,
wonderful.
right?
Make a list of all these things so that we can get
Yes.
to address them.
All right, take care, folks.
Thank you.
Thank you.
Real pleasure.
Thank you.
Sorry,
Yes.
everyone.
Thank you.
Okay. See you guys.
Any other questions that y'all may have?
I was wondering if you started to put together for during Mental Health Awareness Month, kind of bringing that education to schools, because a lot of people that are attempting suicide or thinking about it are going to talk to their friends first, and their friends aren't going to know what to do. I've had people call me up on the phone and they're like, I'm miserable, I want to do this, and I'm a social worker, so I actually am fine with, I know how to handle those situations, but other people wouldn't. And if we were able to include sort of education during Mental Health Awareness Month, I think that'd be really helpful, or at least in the health class, because that's a requirement for almost everyone. You get to high school, you have to take health, some sort of education within that program.
Good point, thank you.
There are some states that require this, and
Okay.
they require teacher training,
Yep.
and we're really interested to see how that starts rolling out in the states. So that's a research question. If we
And
can
we
show
want to
that,
evaluate those.
yes.
Yeah, again, if you go to afsp.org, we have a whole host of stuff. To that point, we have a model school policy. In some states where, again, they don't want mandates, we've actually put together a 25-page outline that school boards can take a look at, and they can actually put together a mental health policy for the school district. Again, it does not require any legislation, no money, just common sense approach to what's going on. And then there's mental health first aid programs. Do you guys realize that right now we train 12 to 15 million people a year on CPR? We train 400,000 people a year on mental health first aid. So we have a long way to go. And it's got to be for first responders, it's got to be for school personnel, a whole host of people. And not to go after the docs, but the docs and the nurses that's where we're getting the biggest resistance right now. So we have to meet with the American Medical Association and the American Nurses Association to let them know that we're not causing them more problems, but it's almost like the AIDS crisis was in the 70s and 80s, and then it was forced upon people. Now it's a little bit different when you're dealing with blood products, things like that. But I would argue it's no less lethal to the country's future. This is, 40,000 people that we know about that kill themselves each year, 1 million people that we know about that attempt to take their lives. There's lots of people we don't know about. So I think there's a basic fundamental shift that has to occur across the board, inside government, outside government, inside the medical field and outside the medical field. So all of us feel as comfortable talking about depression or whatever as we are about talking about a heart condition or being a diabetic. It's simple as that.
So I was curious more about how you're breaking down the research, because it's a lot of work that's been done on veterans groups and on age, but I was wondering if there was any stuff looking at factors of gender or race, and how that plays into the issue.
Sure. So I think it's always important to figure out where the gender and race piece is, because when you look at the CDC statistics, and we use them all the time, what's the rate for African Americans? What's the rate for Hispanics? But that's adding people in Texas and New York and California that are all Hispanic. So, what does that mean? We do know, as Representative Napolitano said, the Latinas do have higher attempt rates. And, so what's going on? Is that true across all of the U.S.? If you look at the YRBS, it is elevated in many areas. But we also know from American Indian populations, the poverty is horrible. It's worse than third world countries. But we also know there's communities with comparable poverty that don't have suicide problems. What is it that's protecting those people? So I think it's the way you ask the question, and we're working very hard to figure out what are those best research designs, because we've also had applications coming in where people want to study asthma in Hispanic immigrants from Mexico in New Jersey. We're not going to have enough money to do every possible work that we'd love to. So we have to try to figure out some principles of what is it that we can do in terms of adapting this intervention that we think is good. But we need to talk to the people who are going to be the recipients of this treatment, to understand how it works. So that is one thing that's big in the Action Alliance. We're actually using the voice of people who've attempted suicide to say, tell us how to do this better. You know, we've learned a lot from, I think, the cancer area with patient navigators. You know, how do you negotiate these systems? Our healthcare system is still quite a maze. And if you have a mental health issue, it's even more of a challenge. So,
Can I also add, Aaron, to Congressman Katko's point about the dearth of facilities to treat young people? Did you all see the article in the Washington Post the other day where they're now building cancer hospitals more and more in local communities?
Right.
So you don't have to go to Sloan Kettering in New York City or MD Anderson in Texas. So I think, again, today we're talking about increasing federal research dollars. But again, we have to think about how we can bring the medical professionals to the communities. Again, we'll have to start, I mean, realistically, we're going to have to deal with the primary care physicians, the physician assistants, the nurses right now, and then we've got to get your age group. We were sort of chuckling about all of you looking at the group this afternoon. You're half our age, but you're the future. You guys are more willing to talk about mental health issues and depression. You can help us talk to your bosses, convince your colleagues. I mean, all these 3 buildings here on the outside, got to do it. It's just a common sense approach to public health, and it's the biggest health crisis in our country right now.
There's 2 things I want to say. One is we're looking at when somebody goes to attempt suicide, where's the first place they take them? Emergency. But what the emergency departments are not prepared to deal with people that have attempted suicide. So what we're looking at is crisis services that are there, which might give somebody a respite, a break, a place that has somebody with the right training, that has somebody with the right skills, that isn't an emergency department where you're sitting for 3 days waiting for the right psychiatrist to come and evaluate you. So we're looking at some of those other models. And we need your help in exploring those. We're happy to talk with you about it. I'm a public health person, so I want to say one thing, which is that CDC right now only has funding for, what we rely on is the surveillance data, you know, which is how do we know if somebody has taken their life by suicide? And we rely on those data, but there's only 32 states that are funded to collect those data. So we don't have every state even that is able to collect the data. We need national data that's going to tell us where the problems are. We need standard and uniform ways of doing that. So there's so many different strategies that we're happy to talk with you about, that we all do our best to advance. Some things may not be as attractive, like supporting surveillance systems. Doesn't sound so great, but when you think about the power of the numbers, and when we now know that it's the 10th leading cause of death, or 41,000 people die, you know, that captures attention. And when you think about a family or an employer, whatever, whose life is touched, it has tremendous ripple effects.
And Doreen, if I could add one more factoid, 40 million Americans live with depression now. If you add in the number of people who have a substance use or alcohol use disorder, depending on the statistics, let's add another 20 million. That's 60 million Americans. So let's not get people to the point where they're on the ledge or they're about to jump off the bridge. We need to get people in for mental health services. Some of them require counseling and medication. Some require just counseling. Some can get along with just medication and periodically checking in. But again, we've got to make this as common as going in to get your heart checked or your blood checked. So thank you very much for everything.
My name is Erin Boyle, as we were saying. So if anyone is looking into helping with the suicide prevention, my boss would be more than happy to team up to see what we can do to help. Maybe we'll make a handprint and moving forward, make it on everyone's radar.
And I have to thank Gemma Cunningham and Aaron Boyle for, as you all know, they're the structure behind so much of what happens, and they've been the backbone of making this happen. I just want to thank you